Good afternoon, everyone. First of all, I just want to thank Angel and her team for having this listening session in advance of the hackathon, where we are really going to try and make some formidable change in racism.
So, well, first of all, thank you so much for making time today to be with us. Maybe if you can sort of share some of your initial perspective in terms of disparities in women's health. I mean, one of the aspects that we're looking to explore as well within the hackathon is this idea of around intersectionality, meaning not just around race, but the intersection between race and gender, or race and socioeconomics and other components that combines multiple sort of underrepresented or minority outlooks. I guess within specifically women's health, where do you see some of the sort of big disparities that you think some of our participants should focus around?
So, Freddie, that's honestly very much a loaded question. And I think before we sort of get to where we are currently, we really have to start with a little bit of historical context. And so, unfortunately, as we have sort of ad nauseum discussed throughout this listening session, racism and disparities in healthcare have started as far back as when we actually were brought to this continent, to this country. And so from the outset, African Americans were considered less than human, creating the mindset that minorities are disparate from the beginning. And unfortunately, throughout history, we have seen where that particular mindset has sort of carried forward and created the space where we don't get the equitable healthcare that we are entitled to. So just for a little bit of context, you think about, obviously we've heard about Henrietta Lacks a lot here lately, but also even in some of the history that has sort of brought us to where we are in healthcare, there are people to consider like James Sims, who is lauded as one of the fathers of modern gynecology, and is a past president of the AMA. But what a lot of people don't know is that a lot of his advances in gynecology were based on procedures and surgeries performed on enslaved women who didn't give consent or have knowledge of what was happening to them. And then we sort of move forward in history. We consider like Fannie Lou Hamer, who had a hysterectomy when she went in for what was assumed to be maybe fibroid removal. And she lived in Mississippi, where things like that were so common that they actually had a code name for it, a Mississippi appendectomy. And, without going through all of the history that is there, considering now where we are in 2020, where we really should be in a little bit of a better space, but here there was just this big outcry with regard to healthcare conditions and surgeries being performed on ICE detainees without their knowledge or consent. So, we really first have to consider the history to get to where we should be today. And some of what I would say is very much a nod to what Dr. Jeroen mentioned in her discussion, where it's like you in healthcare settings have to meet people where they are, and some of that includes increasing healthcare providers who look like you. And I know that that's not a long-term solution, but it's one that we can look at right now. And if you consider Michael Bloomberg, who has recently recognized the importance of this and started creating avenues to reduce debt in some of the minority medical students, then that's super important. Other things, you need to make sure that like trust is established, that you build rapport, that you're honest and open and relatable to patients so that you can actually have them trust you as a provider to get to where you want to break down those barriers and give them the care that they deserve. Also, it would be important to empower patients in their own healthcare decision making, letting them understand that some of their aspects of care are actually in their hands, and that you're not paternalistic, let's just say, and that this is a team effort. So those are some of the things I think we need to at least begin with, though I know not technologically based. Technology obviously takes time, so we can start there.
I mean, certainly, I think, obviously this hackathon is probably different in nature than our prior hackathons, at least MIT has tackled, because the outcomes aren't just going to hopefully be only technology-based or venture-based or startup-based. And hopefully some will be more nonprofit, some might be more policy-based. But I guess if you had to pick some areas for our participants to potentially really hone down and focus on, where would you have them start?
So I actually spent a little bit of time sort of thinking about this, and I think that where we could have some of the hackathon participants start is sort of leveraging the information that we know, and I do know that this won't cover everyone, citing discussions earlier with regard to healthcare and older patients, but we know that the majority of our patients have cell phones or some access to some level of smart device, cell phone, tablet, etc. And so I think what would be important is to use technology to create things like applications which would allow them access to care with variables that become important to them. So it's not just always a healthcare provider that looks like them, but we have to consider language. We have to consider location, providers that accept their insurance, how this particular provider is related to that patient locationally, because there are a lot of barriers that we have to consider, including transportation. And a lot of patients may be using public transportation because that's their only means of getting around. So I think that that's one way that the hackers could potentially use technology. Another one that I think would be very important is with regard to how feedback is provided immediately after office visits or hospitalizations. As we in healthcare are aware of, we usually get Press Ganey surveys or some level of survey that comes after the visit, but generally not immediately after the visit. If you really consider what you could say are the lowest of your patients, then some of those patients, let's say, are homeless. So sending a Press Ganey survey to the shelter or to the address that's listed, if there is one, is not going to be beneficial because you're not going to get the feedback that you're looking for with regard to how their experience was. So if there was some way that that feedback could be given immediately and captured in some sort of application, I think that would be helpful, not only for getting real-time information from the patients, but also creating accountability in healthcare, because as we know, whenever there's a paper or electronic trail and people can go back and create reference, then that incites action, because then there's, this patient complained of X, what happened here, what happened, where was the root cause analysis to this, how have we created change since this particular thing happened to this patient, be it just a matter of customer service or an untoward event or a poor outcome. So I think those two things would probably be super important for our hackers to work towards regarding how to create or how to innovate technology in hacking racism in healthcare.
And within women's health, are there higher disparities that you think specifically that the systemic racism has had a wider impact on, that you feel participants should be more focused on or aware of?
Unfortunately, absolutely. I mean, we have heard a little bit about the disparities with COVID-19. In my space, there are significant disparities with regard to maternal morbidity and mortality and infant morbidity and mortality, to the point where African-American women are 3 to 4 times more likely to die in childbearing. And so that's really important, because I think that if hackers are creating apps maybe for patient education, which is another space that I think would be important, then they would want to make sure that the education that is incorporated is a little bit culturally competent and culturally sensitive, such that African-American women who tend to be more affected by things like hypertensive disorders, cardiac disorders, diabetes and pregnancy, really then should be equipped with information in an application that lets them know if you have certain symptoms or these certain side effects, if you notice these things in yourself, or if your family members notice, or if you notice this with your baby, let's just say, then you really need to reach out to your healthcare provider immediately, as opposed to just saying, oh, it'll be fine, oh, it'll get better, I will feel better. Because sometimes the patient's level of awareness with regard to what is going on with their body is very important in helping us to diagnose what those conditions are. Like William Osler was quoted earlier today, and it's really important, I think, that we understand. He has a quote where it says, listen to the patient. They are telling you the diagnosis. And I think that that's very important for us as providers to remember, is that 99% of the time, if we really take the time to sit and listen to our patients and pay attention to the information they're providing to us, we will know exactly what's going on. If we take that a step further, then we obviously have to equip patients with educational tools so that they know exactly what information they should be relaying to us.
So there's a question from the audience that's asking, compared with African American, the rate of mortality of other women from minorities is as high as African American women? I don't know.
So compared to other minorities, the mortality rate in African American women, to the best of my knowledge, is still significantly higher. 3 to 4 times, they're 3 to 4 times more likely to die or have morbidity in childbirth. And I do think that's a shocking statistic that is above, specifically definitely above white counterparts, but I think even other minority groups.
And I guess as part of that issue, how much do you put that in terms of, I mean, there's the component of the education component, as you mentioned, but how can the healthcare workforce do better in that perspective in terms of, besides just education, even just how to relay to the patient, how to take this holistic approach to patient care, and kind of unearth some of this subconscious bias or unconscious bias that might be there, whether that's at the personal healthcare worker perspective or at the healthcare system level?
I think that with regard to what other things can be done, it's been mentioned a little bit earlier today, but we really have to engage ourselves in culturally competent care. And what that means is when you're having a conversation with a patient, let's say about how to adjust their diet if they're hypertensive or diabetic, then it's not just a matter of handing them a meal plan and saying, here, follow this, because you really then have to backtrack and say, okay, you know, what do you have access to? If they are a recipient of food stamps or WIC, then you have to ask them, okay, maybe what's your budget? How many people do you have to feed? What can you purchase? And then really work with them individually to figure out how you can create a meal plan that works within the confines of their budget, the grocery stores that are available to them or the foods that are available to them. And that is really, really important in breaking down some of the barriers. At one of my former positions, I actually did a group care for diabetic mothers. And one of the most important things was that the nutritionist and diabetic educator who worked with me spent a lot of time incorporating into the meal plans foods and recipes that were common in that particular culture, so that patients didn't feel like everything was so unattainable for them because we were saying eat, you know, kale and spinach, and that's not necessarily what they had access to. And it's not to say that you take all of those suggestions away from them, because sometimes that level of education is powerful. But then if I'm talking to somebody about having a tortilla, let's just say, then I have to explain, okay, well, if you notice that when you eat one whole tortilla, this is what happens to your blood sugar, then I can't say substitute that with wheat bread. That's not necessarily something that they're going to do every day. But I can say, instead of eating one whole tortilla, maybe do a half of a tortilla or a quarter of a tortilla and see how that affects change, so that I'm not taking them completely out of their comfort zone in something that they're not likely to maintain. So I think if we are very sensitive to what actually are the needs of our patients individually, then we will have a lot better outcomes with regard to education, nutrition, and those goals that we're trying to help our patients achieve.
There's another question from the audience here. Have you found any methods of educating people that works better than others? How do we avoid throwing an overwhelming amount of information at people?
I think, yes, I found a couple of ways that have worked. One of them is the example that I just gave with regard to educating people in the realm of what is normal for them. Other things that I like to do, and I think that some of my other colleagues do, is that when you have patients who are dealing with chronic disease, there's only so much time you have in an office visit. And so it's important to hit some of the high points in the office visit, but then we do hand out, paper pamphlets, handouts, etc. But then also I spend a fair amount of time back and forth in dialogue with our patients. And I think that the advent of patient portals has been very helpful because patients are a lot more open in asking questions. And so there are definitely times when there may be 10 or 15 messages back and forth, just in the context of providing education, making sure that patients are clear about what their plans are. And so technology has been very helpful in allowing us to create spaces for open dialogue outside of the office. Also, the use of websites is very important, I think, to give patients reference points to go back to. So I use a lot of websites that are written in language that my patients can understand to help drive the point home when I'm not in front of them, in the office and they're at home, trying to make sure that they comply with their care.
And you've shared sort of the types of language that tends to resonate better with your patients, with your physician counterparts or nursing counterparts. If they implemented that in talking to those same patients, do they start establishing a similar type of rapport as well, or is there still other resistance or hurdles?
Can you repeat that for me, Freddie? I didn't hear the first part, I'm sorry.
Sorry, it's more because you talked about, how we should try to talk to our patients in their language, so to speak. And so I'm curious if when you've shared that with your counterparts, whether African-American or not, how well that has ended up working out, regardless of who from the healthcare workforce side ends up interacting with that patient.
It's been met with a little bit of mixed review, I will say. In the office that I work in now and in offices that I formerly worked in, there has always perhaps been a little bit of pushback, resistance initially, but then there's always sort of the double back of, okay, so I tried this and it didn't work, and maybe what they tried was their initial approach. And so then it's the come back to me and it's like, okay, so what do I do now? How do I do this? And so I think that sometimes it takes a little bit of time for people to want to engage in that manner. But over time, I think we would all get there. I've definitely seen it improve.
And if you had to think about the types of solutions you'd like to see to, again, make this relationship better, is it more patient-facing side, or is it more targeted at the healthcare system or the workforce side in terms of that?
I think that we really have to approach it from all sides. I think that there are things that we can do to empower patients more with regard to education and providing tools for them. But as providers, we do have to take a step back and look at ourselves and say, okay, what can we do that's different? And then even if we look at medical systems, which we didn't talk a lot about at this moment, but have discussed earlier in the day, it is very true that a lot of the times medical systems are revenue driven and not necessarily as outcome driven as we would like. And so if we really stop to make sure that we are hitting points in all of those areas, patients, providers, and the larger system, I think that is perhaps the best way for us to really tackle racism in the entirety of healthcare and make sure that the entire system is actually rebuilt.
Well, it looks like we've run out of time, but thank you so much for your time, Dr. Wilson, and your insights. If you have any last closing remarks or advice for listeners.
I would just like to say thank you for having me. I'm very excited to continue to work with the Hacking Racism team to make sure that we break down some of these barriers in healthcare and really work towards providing the very best care for not only the African-American patient population, which we're focused on, but moving forward, all of the patients, so that, we are essentially at our best at all times.
And so with that, we'll move on to the next session, and I'll turn it over to Angel.